Good morning, hello, namaskar from New Delhi. We are starting our mini conference. So I'm sorry, but Dr. Kadaliud, who had the first session from Mexico, has not joined. So we'll take a session when he joins. We'll start with Dr. Souvik Maitra's session. So I'm Dr. Tapesh Bansal, founder president of Young India Intensivist Forum, a free non-profit educational platform in intensive care medicine. I welcome all viewers to this virtual mini conference, fluids around the globe, arranged by our forum, Young India Intensivist, and supported by International Fluid Academy. I am deeply indebted and thankful to Professor Malbrain, President of International Fluid Academy, for his support and getting the conference organized. Many streams make a river, and many rivers make a sea. And International Fluid Academy is the sea to which we are all grateful for providing a free platform, educational platform in fluids. Today, we are going to have esteemed speakers from all over the world, and I am thankful to each and every one of them, including all the moderators. There will be 3 sessions, 10 to 12 approximately, then evening session from 4 to 5:30, and then a night session from 8 to 9:30, Indian Standard Time. These sessions have been arranged so that they cover different time zones, and viewers from all over the world can at least attend some of the sessions. So thank you very much, everybody, and I hope everybody has impactful learning and a good time. Over to you, Professor Uma Hariharan.
A very good morning to all of you. Thank you, Dr. Tapesh. Hope I am audible.
Yes.
Okay. So without wasting any more time, we would like to go straight to the topic, and we will start with our second speaker for today, that is Dr. Souvik Maitra. He is additional professor of anesthesia and critical care medicine at All India Institute of Medical Sciences, New Delhi. He has many publications and journal articles and chapters to his credit, and he will be dealing with a very, very important topic which has a lot of scope of research, and that is perioperative fluids. Is less more? This topic has always been a topic of debate, especially when we are dealing with fluids like normal saline or ringer lactate or sometimes even colloids. So a lot of debate has already gone into this aspect of normal saline, that whether a lot of normal saline infused during the procedure has caused problems in the form of hyperchloremic acidosis, gut edema, and sometimes several other fluids whose excess may cause more harm than good. So let us now hear it from our stalwart, Dr. Souvik Maitra. Dr. Souvik, please, you can start sharing your slide and your presentation.
Thank you, madam, for your kind introduction to the topic. And as you have already said, that for practical purpose, it's an is the slides visible to all?
No, your slides are not visible. You first have to start sharing your screen. Dr. Tapesh, have you made them the panelists?
Yes, that is the thing.
So you first have to share your screen and then start sharing your PPT.
I think I'll not be able to share the screen unless I am made co-host.
Yes.
Dr. Tapesh, you are able to share. Please share.
Yes.
Yes, you're sharing now.
Yes,
okay,
yes. Now we can see your screen. Can you make it full screen, please? Yeah, now it is full screen.
It is a full screen, na?
Yes, it is full screen.
Sure. Is it still full screen or a presenter view?
No. It was earlier full screen.
Now, okay. Just a minute.
Yes.
Full screen now?
Yes, absolutely full screen.
Thank you, madam.
Thank you.
So we'll be discussing in the next 15 to 20 minutes about the perioperative fluid therapy. The title of the topic is interesting, as Dr. Bansal made it, is less is more. Let's see whether actually less is more or how less is more. Let's discuss first why we need to study about fluid therapy. in the perioperative medicine. In the perioperative medicine, the fluid therapy is almost linearly related with the postoperative outcome. The cumulative fluid balance at the end of surgery, at 24 hours, at 48 hours, and at 72 hours also has been associated with a, just a minute, I'm having a pointer. So this is associated with a increased ICU admission and mortality. So that's mortality persists up to 30 days. So almost linear association between a cumulative fluid balance and the mortality. And interestingly, a negative cumulative fluid balance at the end of the surgery at 72 hours is associated also as a worst outcome. Obviously, the slope of this outcome is less than the positive cumulative balance. So it is understandable both that the positive and a negative cumulative balance also is associated with a worse outcome. An old study, this is old data published from a surgical ICU in 1990 that showed that postoperative weight gain. Postoperative weight gain is one of the very objective parameter for increased cumulative fluid balance is associated with a worse outcome. In patients who had a postoperative weight gain of more than 20%, though it's old data, none of them survived in the surgical ICU. On the contrary, if the postoperative weight gain is less than 10%, the mortality was around 10%. So the fluid in the perioperative period is important, and probably the amount of the fluid is the most important thing that we need to know. Now, before going into the basics of fluid therapy, let's see how why fluid therapy, how let's look into the very basics of fluid therapy. This is important because for our resident and fellows, so how the fluid is distributed in the body. As we all know, in male and female there is a slight difference, so around 55 to 60% of our total body weight consists of fluid. Amongst them, 1/3 remains in the extracellular fluid, and amongst this 1/3, the 20% remains in the plasma. So fluid therapy means essentially we understand the plasma. So we are more concerned about the plasma volume and the amount of plasma that remains in a human body. And these interstitial fluid, this is in equilibration with the plasma in health and with different diseases. So our aim is not to change this balance, this fine balance, keep this balance as precise as possible by our therapeutic intervention. So this is in a very brief, the distribution of the electrolytes. All of you know, I'm not going into the detail of it. Now, before going into the clinical application, just a quick recapitulation of the Stirling law. So what does it say? It's an old concept by Dr. Stirling, and it basically what it emphasizes that the net fluid filtration at the capillary is a function of the plasma protein concentration. So it is primarily, there's a balance between the capillary hydrostatic pressure and the colloidal oncotic pressure. It's the interplay between these two which determines the amount of fluid translocation across the capillary. Now, this concept has been challenged subsequently both by the animal studies and human studies, because the plasma protein actually contributes up to 30% of this net fluid filtration, not more than that. And the concept of endothelial glycocalyx has come into play. That glycocalyx is the major regulator of plasma filtration, both during health and the disease. Now, as we all know, in sepsis, the glycocalyx is degraded significantly, but there is growing body evidence also in the perioperative period, particularly after major surgery, major abdominal surgery, and trauma also. There is a significant disruption of the glycocalyx layer, albeit less than what happens in sepsis, and it recovers earlier also. But these concepts needs to be remembered when at the time of application of our concepts of fluid therapy. Now, what is the rationale? Why do we need fluid therapy in the perioperative period? Because in the perioperative period, obviously the patient is first aid. Many a times, though the number has come down nowadays, many patients undergo a bowel preparation for surgical reasons. And for these patient needs, as the fasting period is continued in the throughout the perioperative period, in the postoperative period also, depending upon the complexity and nature of the surgery, there is blood loss and there is a evaporative loss during the surgery. So the preoperative fasting these things is quite constant for most of the patients, and the maintenance fluid requirement. Rest of the things are variable. Like bile preparation, some patient might or might not require. Amount of blood loss is variable, and the evaporative loss also depends upon the complexity of the surgery. In this context, I want to discuss one concept is a third space loss. Third space loss came to the 1960s. So a group of physiologists and surgeons, they hypothesized that during major surgery and trauma, some amount of fluid is extravasated from the intravascular space to a space which is not the interstitial space. So the first phase is the intravascular, the second space is the interstitial, and there is a loss of fluid from the intravascular space to a third space, the hypothesized third space. So during our fluid therapy, we need to consider the third space loss also. Subsequent researches, the recent years, like last 10-20 years, it has been shown that the existence of third space has never been proved. And the current recommendation does not allow us to use the terminology third space, and the replacement for the third space loss is not usually done in contemporary perioperative practice. So what is the goal of the perioperative fluid therapy? So there are several physiological alterations in the perioperative period. So our ultimate aim is to maintain the intravascular volume as close as to the physiological range possible. And with the intravascular volume, it is expected the cardiac output will remain in the physiological range, which will help to maintain the end organ perfusion. And thirdly, we should avoid the interstitial edema. As you all know, interstitial edema is associated with the worst tissue healing, anastomotic leak, surgical site infection, and definitely poor outcome. So these are the three major goals of perioperative fluid therapy. So regarding perioperative fluid therapy, we need to know three things. What types of fluid we should use, what is the amount of fluid we should use, and what are the endpoints. So what should be your end goal of your fluid therapy in the perioperative period, that includes in the postoperative fluid. So you have several types of fluid available commercially across the globe. The amount can be controlled, yes, by the physician, and the endpoint has to be decided. Let's see one by one. So first come to the preoperative fluid. So the current recommendation is that all patients should be allowed to have a clear fluid till 2 hours of surgery. So this has been proved to be safe, and not only safe, it is effective also. It helps to maintain the plasma volume in the preoperative period. It increases the patient satisfaction. Simultaneously, a new concept has come in the last decade, is the preoperative carbohydrate loading. Is it beneficial? Yes, probably. The preoperative carbohydrate loading reduces the insulin resistance. So with the reduction in the insulin resistance, there is a reduced catabolism both in the intraoperative and the postoperative period. The reduction in the catabolism actually helps in maintaining the glycemic status of the patient and helps in tissue healing. Simultaneously, patient satisfaction and the postoperative nausea vomiting is less with the unrestricted use of preoperative fluid. So in many centers, before major surgery, the anesthesia and the surgeons, they always encourage the patient to drink as much as clear water or carbohydrate loaded drink as per the hospital protocol, as much as they want. They encourage the patient to have in the preoperative period. Now, at the time of induction, so if the patient is fasted for 2 hours, is there a hypovolemia? This is an important question. So there is a hypovolemia, but this hypovolemia is not very high. So physiological studies have found when you start a surgery, so there is some degree of hypovolemia around 200 ml, and it rarely goes beyond 400 ml unless there is some specific reasons, like patients undergoing an emergency surgery who are already in shock and volume deficit, or patient has undergone significant bowel preparation for surgical reasons. So there maybe preoperative hypovolemia may be significant, but usually there is some minor degree of hypovolemia. So the blood volume remains nearly normal in the preoperative period in patients who are undergoing elective surgery unless there is some other cause. So let's come to the practical consideration. As in the beginning of my presentation, I have shown that perioperative fluid therapy has several components that we try to provide the maintenance fluid for maintenance of the basal metabolism, counteract the evaporative loss, the blood loss, and there is a other loss, like because of other relative hypovolemia, like because of anesthesia causes all kind of anesthesia, whether it inhalation or intravenous anesthesia, causes some degree of venodilatation and vasodilatation, which causes a relative hypovolemia. So you have to think about the maintenance fluid. And along with the maintenance fluid is usually a fixed dose. A fixed dose doesn't fit for all. So additional values are often required, and the blood volume replacement. So it depends upon the complexity of the surgery and obviously the actual blood loss that is happening during the procedure. So what is the maintenance fluid? The current recommendation is that isotonic balanced salt solution, like a linear lactate, plasmalide, multi-electrolyte isotonic solutions are recommended for maintenance fluid. Now comes to how much you should provide. So there is a controversy. Some authors recommend, okay, you utilize a less maintenance fluid of maybe 3 ml per kg per hour. Some recommends, okay, 5 or sometimes 8 also ml per kg per hour, which is required for the insensible and sensible loss during the surgery. So that's why I have kept a recommendation in maintenance fluid. This is 3 to 5 ml per kg per hour. It is reasonable for a patient's up to 60 to 80 kg of body weight. Now coming to the additional fluid boluses. Yes, additional boluses are required. So additional boluses are required first at the time of induction of anesthesia. Most of the hospital protocol includes some crystalloid boluses at the time of induction of anesthesia to counteract for the preoperative hypovolemia and also the anesthesia-induced vasodilatation. So how much fluid should be given at this point of time? Maybe around 5 to 10 ml per kg of body weight, depending upon the hemodynamics of the patient. So subsequent additional fluid boluses can be a goal-directed or based on the clinical judgment. We'll come to it later on. It can be crystalloid or colloid, and the volume. So these two things needs a detailed discussion. Volume, the classic recommendation is around 200 to 250 ml of boluses should be used in at each time. So some institute use relatively less amount of fluid for boluses, maybe 100 to 150 ml. But for a patient who is not risk of fluid overload, probably a volume of 200 to 250 ml is reasonable. Next, coming to the goal-directed. What is goal-directed fluid therapy? Goal-directed fluid therapy is that you tailor your fluid therapy based on a physiological variables that are monitored at the time of surgery, like pulse pressure variation, stroke volume variation, systolic pressure variation, cardiac index, and these variables can be measured by a number of devices. And what is our clinical judgment? Our clinical judgment are traditional parameters like blood pressure, heart rate, a tachycardia, a decrease in the blood pressure, and the urine output. Now, remember, during the surgery, the blood pressure, heart rate are affected by so many factors, including pain, nociception, awareness, temperature, handling of the tissue, sympathetic stimulation. There are several factors control these factors. So they are neither very sensitive nor very specific. Thirdly, the urine output. Urine output is also variable, particularly at the time of abdominal surgery. It is the handling of the splanchnic viscera, handling of the peritoneum, and also the anesthetic drugs. They also affect the urine output, limiting its sensitivity and specificity for identification of hypovolemia. But these goal-directed variables, it can be derived from a number of devices. Now, the question is that whether these should be used routinely or not. So before going into this, just a snapshot that how this goal-directed fluid is helpful in identification of hypovolemic patients. Probably a passive response of cardiac output in passive leg rising is the best variable to understand or identify hypovolemia in a clinical setting. But in perioperative period during surgery, which is almost always impractical. What are the other things remain is our stroke volume variation and the pulse pressure variation. Inferior vena cava variation, though it is appealing during surgery, it is often not possible to understand because of the surgical reasons. Central venous pressure, yes, it is used, but definitely the sensitivity and specificity is less. Still, a central venous pressure during positive pressure ventilation, if it is less than 8 millimeter of mercury, probably there the patient is hypovolemic. Now let's come to the fact whether the goal-directed therapy should be routine or it should be used in a group of patients. So it's a very recent meta-analysis published 2 years back, around 2 years back. It shows that Yes, probably it is beneficial, but not in all patients. It is beneficial in high risk cases and in the very high risk cases, and particularly if the patient is undergoing a GI surgery or an abdominal surgery. And these variables are also probably not interchangeable. If you use a pulse contour analysis or plate curve analysis, probably, particularly the pulse contour analysis, the sensitivity of the device is more. And with the type of fluids you are using, it is beneficial in this particular group of patients. And it is helpful in reducing the incidence of respiratory complications and the surgical site infection and reducing in anastomotic leakage. So it can be used in a patient specific or a procedure specific scenario when a moderate to high or a high risk patient is undergoing a high risk procedure. Routine recommendation, yes, cannot be recommended at this time. Next, coming to the first, crystalloid or colloid, what should be used? Yes, colloid has their physiological benefits that definitely the volume of expansion is higher, 30 to 50% or even more. And the plasma volume expansion lasts longer. So increase in cardiac output with the volume infusion lasts longer and it stays in the postoperative period also. And with this rationally, when you use a less volume and then it's a less interstitial edema because of the less translocation of the fluid at the end of the capillary. So there is a physiological rationale. Now, what is the concern? As you all know, there is a serious concern of acute kidney injury and increased requirement of renal replacement therapy in critically ill septic patient. And definitely there is a risk of coagulopathy and increased cost of care. So this landmark meta-analysis, which was published in 2013, which shows that definitely in critically ill septic patients, the use of colloid is not probably reasonable. Now, what about in perioperative period? There is no such data suggests that in elective scenario, elective surgery patients not in sepsis, the use of starch, particularly the low molecular weight 6% heterstarch along with the lower molecular substitutions. The newer generation starch is probably safe in patients who are undergoing elective surgery without sepsis. The real world data beyond RCTs, there is a study published from our institute 2 years back also. It decisively showed, yes, the use of low molecular weight starch, particularly the 6% hydroxyethyl starch, is not associated with a worsening kidney dysfunction or coagulopathy in patients undergoing major abdominal surgery. And this meta-analysis also from our research group, this also showed, okay, there is not much probable harm associated with the colloid in comparison to crystalloid when a low molecular weight starch is being used. Rather, in 2018, a randomized control trial published in Anesthesiology, here the author used a fluid therapy by a closed loop technique. It showed that use of crystalloid is probably having a worse outcome than the colloid in patients who are undergoing major surgery. But remember, these patients were used, in these patients, the fluid therapy was used by a closed loop system. So human cognitive bias probably was avoided. Now, coming to the newer colloid, albumin, whether it can be used. Yes, albumin is useful in expanding the plasma volume. Probably the 20% albumin is more useful than 5% albumin, and their half-life, plasma half-life is more. They causes less edema and more plasma volume expansion than our crystalloid. But there's a single study available in 2024. It's a physiological study. It didn't show us any clinical outcome, improved clinical outcome. So in the absence of large clinical data, routine use of albumin cannot be recommended at this point of time because of the cost and other possible adverse effect of albumin. Rather, a 2023 study reported a worse outcome with albumin, but definitely it's a retrospective study. There are a lot of biases are involved in this study. So I'm not saying that albumin is harmful, but definitely further researches are required before routine use of albumin in the perioperative period for volume expansion. Now, lastly, coming to the end point. The title of the talk which Dr. Bansal suggested is that less is more. Let's see. So there is a concept of restrictive fluid therapy that came in 2003. The publication of this study is by Dr. Brandstrup and team. It showed that in colorectal surgery, if you use a restrictive strategy where the median fluid use around 3 to 4 liter were associated with an improved outcome, less weight gain when in comparison to a liberal fluid therapy where more than 6 liter fluid of use. That actually ushered the period of restrictive fluid therapy. So 3 to 4 hours for a 3 to 4 hour surgery, around 3 to 4 liter of fluid was probably reasonable at this point of time. Subsequently, several studies were published in favoring the liberal fluid therapy, and the meta-analysis also suggested that liberal fluid therapy is probably beneficial. Now, the question is that what is restrictive, what is liberal? So after publication of this first study in 2003, the people started using a less fluid in the both in the liberal group and the restrictive group. So the definition of liberal and restrictive used in different studies is different, which hindered us to draw a meaningful conclusion in this remark. Now this confusion reasonably ended in 2018 after the publication of the relief trial. So it decisively showed that if you use a net zero valence fluid therapy, which is the you can say that end point of all restriction, fluid restriction, were associated with a worse outcome, particularly in terms of acute kidney injury. So the acute kidney injury was more when a zero valence fluid therapy was used versus a moderately liberal fluid therapy. Now there is a catch. The moderately liberal fluid therapy, which was used in this study, was actually the restrictive fluid design of Dr. Brandstaff's study. So these restrictive fluid therapy and liberal fluid therapy, these two terminologies are very vague. Rather, you should stick to the fluid balance or amount of fluid used during a average duration of surgery. So these study used a median volume of 3000 to 4000 ml during a 3 to 4 hour surgery with a median infusion rate for around 10 to 11, 8 to 13. So moderate liberal therapy was probably beneficial than a net zero valence therapy, and these debate probably ended in 2018. Now, lastly, coming to the type of the fluid therapy, as I have discussed the crystalloid and colloid, that's coming to the balanced solution versus saline. As you all know, yes, there is a lot of physiological benefits of balanced solution, which translate to a lower hyperkalemia and lower acidosis, and probably some beneficial effect in critically ill patients also. I'm not going into it. But in perioperative period, if you are using an 1 to 2 liter of crystalloid, in that case, probably there is not much difference between the ringer lactate and normal saline. Obviously, the cost of normal saline is less. So if you're using 1 to 2 liter of fluid, probably the difference doesn't make sense. But still, all the international guidelines advocates the use of balanced solution because it is more physiological. And especially in kidney transplant patient, the balanced solution causes significantly less acidosis and associated with a better outcome. So the systematic review and meta-analysis also doesn't suggest any benefit of using a balanced solution, but in a specific scenario, you should use a balanced solution. Lastly, coming to the summary, yes, a moderately liberal fluid therapy strategy where a 1 to 2 liter positive balance at the end of the surgery is the reasonable ultimate goal. But obviously, that depends upon the surgical complexity, time of the surgery, duration of the surgery, and also the blood loss. Balanced solution for maintenance and volume replacement. And goal-directed therapy, if it is available and if not cost a constant, it should be used, particularly in moderate to high-risk cases. And these moderate to high-risk case includes both the patient-specific risk and the surgery-specific risk. And the postoperative fluid therapy, in the absence of any ongoing loss, it should be around 1.5 ml per kg per hour. So this ends my presentation. Thank you, Dr. Tapesh and team.
Yeah, thank you, Dr. Soumik. It has been a very, very illuminating and enlightening talk, and many myths and other problems associated with perioperative fluid therapy have been quashed. And probably
stop the share screen. Stop the share screen, please. Yeah.
Yeah. So the perioperative fluid therapy has always been a point of study, debate, and research since a very long time, and I think the debate shall continue in the future as well.
Yes, absolutely. There are a lot of unanswered questions still there.
Yes.
So regarding the type, amount, use of albumin, it's coming in a big way. A lot of researchers are undergoing. We're waiting for the result of these. Probably the new guideline will evolve.
Different patient populations, patient populations have different kind of results vis-a-vis balanced
madam.
crystalloids, normal saline,
Absolutely.
and colloids.
Yes.
But yes, several of the older colloids have, of course, been phased out, like gelafuscin, etc.
Exactly.
But yes, the debate still continues, and each and every population which undergoes surgery and the type of surgery, for example, it is a cancer surgery,
Yes.
or a very prolonged surgery wherein there are a lot of fluid shifts. For example, when you have a patient of, let us say, CA ovary, extensive metastasis with
Dissection.
ascites,
Yes.
with
Yes.
hydrothorax,
Yes.
and the surgery is quite prolonged, because not only they do
sometimes 12-hour surgery, sometimes it is
yes.
12 hours surgery,
Yes.
and this cytoreductive surgery causes a lot of electrolyte disbalance,
Absolutely.
acidosis, acute kidney injury,
Absolutely.
a systematic inflammatory response. So these particular surgeries where there's a lot of systemic inflammatory response that happens after some period of time, we usually prefer a early use of vasopressors, like particularly
Yes.
noradrenaline. So this is a special scenario where a lot of fluid shift, use of high-peak chemotherapy, other
Yes.
factors are there, where we prefer to use a early use of vasopressors. So when to use vasopressors during perioperative period in the absence of major blood loss? No, there is no such
There are no
recommendation.
consensus guidelines.
There's no
Yes.
consensus at this
Yes.
time of
Yes.
period. But yes, if it is started relatively early and the hypovolemia is also
Yes.
collected, like use of this scenario where sometime we use albumin, particularly patients with low serum albumin level in the preoperative period. Though I agree there is no such hard evidence to do so. This is our strategy.
And as you rightly pointed out at the beginning of your lecture, our main goal is to maintain end-organ perfusion.
Yes.
And to maintain the intravascular volume. Because what is happening at the microcirculatory level, we really
Yes.
cannot predict. Because that is
predict.
what
Absolutely.
is going to determine whether the patient is going will go into extravascular edema, or whether the patient will have
Right,
gut
madam.
edema, or whether the patient will
Yes.
have acidosis. So all these things, they require greater depth RCTs to understand what exactly is the correct fluid, the volume, the type, and the duration in which you should be infusing them.
Yes, yes, ma'am. As you rightly pointed out, that there is a special group of patients, of, like you pointed out, CA ovary,
Yes.
undergoing cytoreductive surgery, and often they end up in surgical ICU, like patients undergoing hepatobiliary surgery, like Whipple's
Yes.
procedure. So positive fluid balance is, there is multiple intestinal anastomosis. So a significant
Yes.
positive fluid balance is harmful, probably.
And electrolyte balance.
And electrolyte disbalance, yes. So
Yes.
this is an area where further researches should be done, and we are expecting few more data will come.
Yeah, and in surgeries like robotic surgeries, which has actually taken the world by storm, the surgical as well as the anesthesia field, these they require restrictive fluids.
Yes.
And that is actually a challenge, because sometimes there can be occult blood loss also.
Occult blood loss also.
Yeah.
It's difficult to assess. At many times,
Yes.
it's difficult to assess. It happens in the pelvic cavity, and you can only see them in the screen. This is one group. And as of now, the guidelines are actually just for guiding. Obviously, a 1 to 2 liter positive fluid balance cannot be advocated for patients undergoing a lung resection surgery.
Yes.
Like patients undergoing a robotic prostatectomy. In this group of patients, a little more restrictive. But how much restrictive? Maybe 1 liter positive. That is, we don't know the answer.
Yes.
It depends upon the clinical judgment.
Yeah. Even with the use of non-invasive, like stroke volume variation and other diagnostic and these modalities, then also we are still, in paucity of RCTs to give us consensus guidelines.
Right, ma'am. Absolutely. Absolutely.
Okay, ma'am, let's move on. Thank you so much.
Okay,
yes,
thank you.
Please.
Thank you, Dr. Tapesh.
Yeah.